All right. Well, welcome everyone to the Health Services Research Center Grand Rounds. I'll start off with some quick housekeeping notes as folks are continuing to trickle in a little bit. Um, the first is, as I'm sure you got the warning or the notification as when you logged in, the webinar is being recorded and will be available to view from the UH Research and Education Institute website. Um, as you're logging in, please make sure that your microphones are muted and please keep them muted throughout the presentation. If you need any technical assistance, I would suggest reaching out to our R&E team. Nicole Bollinger and Abigail Zona Patel are both on the call and are available for help. If you have questions that come up during the course of the presentation, please enter them into the chat. Those questions can be seen by all attendees. You do also have the option to submit them anonymously if you prefer. With that being out of the way, I just want to give a brief introduction. My name is Kevin McKeno. I am a pediatrician and child psychiatrist and health services researcher here at University Hospitals. And I have the distinct pleasure to introduce Dr. David Sheyn. Um, Dr. Sheyn is an associate professor of urology and reproductive biology at Case Western Reserve University and the division chief of female pelvic medicine and reconstructive surgery at UH Cleveland Medical Center. He is a fellowship-trained urogynecologist and a clinician scientist whose research integrates clinical trials, big data analytics, and artificial intelligence to improve diagnosis and management of urologic and gynecologic conditions. Dr. Sheyn's work spans comparative effectiveness research, digital therapeutics, and precision medicine, with projects supported by the NIH, the PCORI, and other major funders. His studies use large-scale data sources such as Epic Cosmos, Trinetics, and the UK Biobank to explore mechanisms and treatment outcomes in pelvic floor disorders, urinary tract infections, and menopausal health. He also leads collaborations developing AI-driven tools for antibiotic stewardship, urinary urgency incontinence prediction, and digital platforms for menstrual health. So he covers quite a wide range of both clinical concerns, research tools, and sort of methods for developing information and impact, improving the health of a wide range of patient populations. So thank you so much for joining us today, and I will hand it over.
Thank you very much, Kevin, for that kind introduction. Thank you to Sam and Yi for inviting me to give this talk. And let me share my screen and we'll just dive right in. Um, I will start by saying that I've been giving a version of this talk since 2019, and I actually think it's really fun because every time I give it, I have to significantly update it. And I'll kind of show in the first few slides what has changed since 2019. These are my disclosures. And these are our objectives. So we'll go through the reasons for why AI is sort of, came out of nowhere. In healthcare, we'll review the potential benefits and risks associated with using AI in healthcare and a path forward for implementing this correctly, rather than causing more harm than good. So we'll start with a few definitions. So broadly, AI is basically any synthetic machine that can simulate cognitive function similar to a human being. And as it evolved, it has developed into different subfields of robotics, deep learning, natural language processing, motion and manipulations, that's like the self-driving cars, and machine learning. In healthcare, machine learning is still kind of the predominant form of applications. This is what's also known as predictive analytics. And this is developing mathematical models that can use large data to make predictions about specific outcomes. And this is related to big data and computational statistics. And as of right now, although that's really shifting, this is how a lot of quote unquote AI is being applied to medicine. For a little historical grounding, AI is directly arising from natural intelligence and from ancient Greece with logic and mathematical reasoning. That's what we're trying to simulate with these machines. This sort of coalesced in the 1930s and 40s and 50s with Alan Turing, who's considered the father of modern computation, where he thought that you can use a binary language, so ones and zeros, that could stimulate a human brain, and we can either do the same kind of reasoning and deduction, or it can be better. As it evolved, it went through these periods of rapid growth and what they call AI winters, where it just kind of stagnated. And this was completely based on concurrent developments of new conductors, our understanding of neurobiology, and computational technology. And as those things evolved, then AI evolved with it. And as it grew, it splintered into those different fields. And even though it seems like AI is a relatively new application, in medicine, we've been using predictive analytics for decades in the form of nomograms and like for Tylenol overdoses for hyperbilirubinemia, predicting breast cancer risk, osteoporotic fractures. These are all still models that are even currently now being used in more modern applications. Um, and this is all directly linked to the development of big data. That's and when we started to collect data through electronic medical records, and we were able to have a concurrent rise in computational power and to store this amount. Everyone thought, well, why don't we use this data to improve healthcare? And when I first gave this talk in 2019, there were a total of 44 zettabytes, so 10 to the 21st power times 44 of healthcare data. And this didn't really change between 2019 and 2022. Last I checked, which was this weekend, there's 181 zettabytes. So that's equivalent of 1.8 trillion libraries of Alexandria, which before it burnt down was considered to be the sum of all human knowledge. And all of this data, all of the atoms that make up this data can fit into a single bacteria. So it's a ton of human knowledge, but it's very compressed. Um, and this has opened a lot of areas of research. So between 1957 and 2010, if you searched in PubMed, AI, or machine learning, or some other variation, there was fewer than 2,000 papers. In 2024, there were 45,000 papers. And again, I checked this weekend, there are almost 600,000 papers with just two kind of broad generic um, terms, AI or machine learning. And if you expand it a little bit, it's probably close to 1 million. So this is just explosion in research and applications, which is both good and bad. So what's different now between 2019 and 2022? One is AI applications have shifted from bench and research to bedside and clinic, and we're just seeing a ton of it in our offices and ORs. The model focus has shifted predominantly from prediction to reasoning. The training data has actually become less trustworthy, and I'll talk about all that a little bit. And there's this large scale deployment across all industries just in the last 3 years that has no evidence of slowing down and is in fact expanding. So going back to a couple of more definitions, there are two main types of AI. The one that is currently being utilized across the board is what we call narrow AI. So this is focused on a single task. Even something that's an LLM that's considered to do a lot of stuff is still technically a narrow AI. It lacks self-awareness or consciousness. It has no emotion. It can perform tasks better or at least as well as a human being. Siri is a good example of this. Um, and like I said, everything in healthcare right now is narrow AI. And this is compared to general AI, which is what we think of when we think of science fiction. So this is something that's either as smart or smarter than a human being. It does have emotion, it does have consciousness, at least in theory, and it can learn. And once we've created it, it just kind of goes off and does its own thing on its own, and who knows what will happen. This is completely theoretical. We are here right now, so this is narrow intelligence. Something happens, nobody knows what. And then we get artificial general intelligence, and then exponentially we get super intelligence, which is something that is significantly smarter than a person. So there's no such thing right now as general AI, as far as we know. Maybe Google or OpenAI is sitting on something, but it's not in the public sphere. And then there's a difference within narrow AI. There's the traditional machine learning methods, and then there's generative AI. And this is a little bit simplistic, but I don't want to get too granular. These are the two main methods that we are currently utilizing in healthcare. So traditional machine learning is, or basically fancy statistics, is relying on big data to learn patterns from specific inputs, and then you get an output, or you can classify observations. It's primarily based on something called supervised learning, where you give it instructions and you define the outcome. And then there's a version of unsupervised learning where it's still anchored in a data set, but you don't give it specific instructions. Traditional machine learning is deterministic, meaning that if you give it the same output every time, or the same input every time, you're gonna get the exact same output every time. And that makes it very easy to evaluate in the traditional scientific way with metrics like the area under the curve and calibration plots. And we can also validate to make sure it works through our standard study designs. You can adjust for things like drift, which I'll talk about later, so kind of model variations over time. And it's grounded in truth, meaning it's the truth that we've defined. So if we say predict sepsis, sepsis, the truth is like what we understand sepsis to be. It will not deviate from that. The main strengths and the where it's best applied is risk stratification. So it's something like, are you at higher risk for breast cancer? Do you need an MRI versus not? Outcome prediction. Again, like, are you going to have sepsis? Image classification, identifying lung nodules, resource allocations for things like surge conditions in the ER and labor and delivery, and then decision support for both patients and clinicians. It is prone to the same weaknesses as a statistical model. So garbage in, garbage out. So it's prone to, if your data is biased and the model is biased, the model can be overfit. So it will lack generalizability, even though it performs really well in the population in which you built. It is non-causal. It cannot make causal inferences. It is like correlation, not causation, because it's still a big data kind of study, and it won't generate any new insights or new data. And this is in contrast to generative AI. So generative AI, you feed it a ton of data, and it learns the underlying probability of this data distribution and then can generate new outputs. So this is typically like text, images, audios, or structured data or clinical notes or what have you. It is not grounded in truth. It is providing what is plausible, not what is correct, which is why it hallucinates, and hallucination is actually a feature, not a bug. And unless they figure out a different way to run large language models where it is sort of grounded in truth, hallucinations are always going to be a part of it. I have new data in quotations because it's always derivative of what we are giving it. Right now, it is not capable of really truly making new insights beyond what a human being can. And it's completely black box. We have no idea what's going on under the hood or how it's coming to specific conditions. And if we give it the same, it's non-deterministic. So if we give it the same input over and over again, each time it will give you a different output. It could be slightly different or it could be completely different. Um, and the reason for this is the way the models it's based on. So there are two main types of generative AI kind of base models. One is Bayesian. So this is based on probabilistic theory. That includes both uncertainty and prior knowledge. So if you have a bag full of red and blue coins, it can give you a prediction of how likely it is someone will pull a red coin out of this. If anyone's super interested in how this works, Daniel Kahneman was a behavioral economist that wrote a bunch of books that are very accessible to people who are not economists, that explains what Bayesian modeling is. Most models right now are not Bayesian, but that is an evolving field because they can adjust for some of the hallucination problems that occur in current generative AI. And that is because it is right now it's based on these neural networks. So these are completely modeled on mammalian cerebral cortices. It consists of multiple layers of neurons, or what they call nodes, and then the connections of synapses are called edges. So you feed it an input, bunch of stuff happens that we don't know, and then you get the output. And these neurons are then grouped into different layers. The more layers you have, the more sophisticated the model is. And that's what large language models are. There are multiple different kinds of artificial neural networks, and specifically they're called generative adversarial networks, or GANs. And there's two specific networks. One is a generator that creates the data, and then the discriminator, which distinguishes real versus fake. And this is where the hallucinations happen. Most of them are multiple layers. The most sophisticated ones are 96 plus layers, which is extremely advanced. And this is exponential growth. So the next marker would be close to 200 layers, which would be very, very sophisticated. Um, so how did we land from this kind of more theoretical stuff to we're using ambient AI in our clinic. And this can very directly be linked to the release of ChatGPT in December of 2022. As the day came out, I got at least 20 text messages from different people. Have you checked it out? And I actually hadn't heard of it. And then I sat down and this was amazing. And I'm sure anybody that sat down and played around with it thought that this was going to completely revolutionize every industry, and people in healthcare were no different. Since that day, there has been a sevenfold increase in adoption of AI-specific tools in healthcare. 27% of health systems adopted some version of AI compared to 9% of the entire non-healthcare economy. In 2025, we spent threefold what we spent in 23 on AI, which is 1.4 billion, and this is not slowing down. In 23, 38% of clinicians reported using some sort of large language model. So this was a year after ChatGPT came out. In 2024, this is just the most recent data, 66%. Right now, it's probably well over 80% of people using large language models in the clinical setting. And then 40 million Americans have used ChatGPT for some sort of healthcare related question, including people in my office who come in asking about what ChatGPT said. Um, there's several drivers for this beyond the cool factor. One is AI does seem to have better administrative and financial efficiency. So in an era of reduced reimbursement and um, uh, sort of administrative delays, if we can automate some of this stuff, it would be make things easier for everyone. Patients are demanding 24/7 access. Doctors have to sleep, but AI doesn't have to sleep. And there's also a significant healthcare worker shortage that's being made worse every single day. So we're on pace for being 200,000 nurses short and 100,000 physicians short, which results in longer wait times. And already people are trying to combat this with AI, which I think it was last year that Mass General Brigham launched Care Connect, which was just a fancy way of screening patients and collecting data. It's not really diagnosing them, um, but it is people are reporting that it makes things easier, and it's easier for them to get in contact with a clinician through something like this. There's also potential for significant research applications, like drug discovery and development of personalized medical care. And perhaps the biggest driver of this kind of headlong race to implement this is this kind of space race mentality. I don't know if anyone knows this person. This is Baymax from Big Hero 6. So when I think of AI in healthcare, this is a medical robot that will just do a blood prick and then diagnose you immediately. It's like Theranos, but like a lot more cuddly. And there are some currently deployed potentially beneficial applications using AI in healthcare. The most common one is imaging. There's automation of administrative and certain workflows, patient monitoring, and applications in clinical trials. And I'll go through each of these one by one. Um, so this, by far, imaging is the most mature application, and I think it's the target because it's on computers, and so is AI. So people just assumed it was an easy um, uh, thing to automate, which it turns out it isn't. But already major platforms have AI-based solutions like GE, Philips, and Siemens. They're all putting out stuff on their scanners that utilize AI. There are also third-party vendors that can use improved detection of disease on imaging, as well as on other sort of visual media like EKGs, some of which we're using here at UH. It in a research setting, it definitely helps improve detection. So it's studies have shown it identifies 94% of malignant lung nodules. In mammography, it's reduced false positives by over a third and reduced biopsies by close to a third, which is a huge thing in high volume centers. Um, it has led to increased detection of intracranial hemorrhage in stroke patients. It has superior accuracy to general, but not neuroradiologists for cranial aneurysms. It can detect pancreatic cancer by up to 3 months sooner than a human person can, or a human being, but whether that translates into reduced mortality or disease-free survival is TBD. For obstetric ultrasounds, and ultrasounds in general, it's improved turnaround time and has reduced the exam by itself by up to 90% and improved detection. There's also, I don't have this on here, but I don't know if anyone saw the conference with Dr. Oz where he was talking about robots doing ultrasounds in rural Alabama. I, I don't think he fully understands what's going on, but there is a company called Melody that uses a platform where it's basically like a remote robotic ultrasound where a tech or a nurse holds an ultrasound um, over a patient, and then it's linked to an ultrasound to a sonographer who's trained in perinatal ultrasound somewhere else that can do the ultrasound. And it again, it seems to work, but it's never been deployed on such a large scale. Um, with regard to administrative tasks and workflow, it's not really AI. It's more like automation. And AI sounds sexy, and I have a close relative that works in finance, and he said like no one will listen to you, no investor will listen to you unless you put AI, whether it's true or not. And I think that's what's going on with these applications. But that being said, they are fairly effective, especially in collecting revenue, improving billing accuracy, which is a major issue in healthcare where we get denials for the silliest things. So if you can sort of fight fire with fire because those companies are also using AI. Um, Clearly, it improves coding accuracy, and systems that have implemented this have reported significant improvements in reimbursement and a reduction in prior authorization denials. Um, Ambient scribes have also been shown to be very helpful, especially to reduce documentation burden. Um, there was a study out of Yale and University of Chicago that found that burnout was decreased from 50 to 39%. And while that's good, a 50% rate of burnout is insane. Something else is going on. And 39% burnout, also not that great. So these are like very incremental improvements. There was another study out of Duke that I didn't have on here where they showed pajama time was decreased from 30 minutes to 15 minutes. So basically how much you're documenting outside of work. But if you're spending millions of dollars on a scribe, I better not be doing any documentation in my pajamas. Like it doesn't matter if it's 50, it has to be like negative 50% for it to be worthwhile. It with regard to patient access, it's being used to some effectiveness. I don't know if that's being deployed absolutely correctly, but it does send automatic reminders and it reduces no-show rates by up to 50%. One of the biggest values is it can sort of predict no-show rates and then fill those slots with patients. Now, sometimes that leads to double booking or even triple booking, but it has been shown to increase capacity. Once these models become a lot better at prediction, then maybe it will prevent overbooking without having an empty slot. This is a clear area where something like AI could be beneficial. Um, there have been a lot of emphasis on predicting adverse events, both in and out of the hospital setting, and multiple models and companies have sprung up. One of the most successful, at least in a research setting, was something called the Concern Early Warning System, which documents or reviews nursing documentation in real time. And there was a large randomized trial of over 60,000 patients where it showed that mortality reduced by over a third, which is incredible. It also reduced sepsis by 7.5% and reduced LOS by 11.2%, which is not that much if you're looking at hours because they could, instead of 24 hours, they'll be there for 22 hours. It's not making a huge dent, but it is like sort of on the right track. And there are multiple of these kinds of models running around, specifically looking at sepsis. One of the best applications for this has been integrating AI monitoring with wearables, either like a Fitbit or something we have here called Massimo, which is a little bracelet that patient wear. They can monitor their vital signs continuously without making them stay in a bed. And studies have shown that it can detect clinical deterioration 17 hours before it actually happens, which is, on a bigger scale could be really, really amazing and a paradigm shifting. Um, Labor monitoring, the huge problem with a very high C-section rate. There are some models that can reduce fetal outcomes by 91%, but they actually didn't look at like the flip side of that coin, which is how often are they doing unnecessary interventions. There are some consumer-facing models, that, especially for fertility tracking, that have been shown to be effective. our very own company, Hemaptics, which is a decision support tool for transfusing blood products that has been shown to reduce blood product utilization by 30 to 50% and has saved over $50 million. So again, a very narrow task, but extremely beneficial to patients and the hospital system. Um, and one of the newer applications that's been coming out recently has been using AI in clinical trials. Right now, it's primarily being applied to patient enrollment and matching the correct patient with the correct study by screening the EHR. And again, this was implemented most successfully at Harvard, where they've increased enrollment in clinical trials by up to 65%. A lot of these models use natural language processing to identify patients in the chart um, both just in general and also focus on underrepresented patients, which is a big deal. They can screen for social determinants of health and really prioritize enrolling those patients or at least reaching out to those patients. Trial design is a relatively new application of AI where you can run multiple simulations and design the most pragmatic trials. And then AI can monitor for any sort of protocol deviations and can automate data collection both from patients and synthesize the data so you don't have to do data cleaning afterwards. So those are the real applications, and these are a little bit more kind of pie in the sky. And this is where I'll highlight some of the work that we've done. One potential problem and application of AI that can solve this problem, or it's a true problem, but potential application is screening for low prevalence and high mortality conditions. So these are things like ovarian cancer, pancreatic cancer, bladder cancer. They don't occur in a ton of patients, and we don't have any successful ways to screen for them. And they are just absolutely terrible when we identify them because we identify them too late. Um, a lot of models have focused on prognostication, like once you've actually identified. What we did here was we used data from the PLCO trial, which was screening patients for prostate, lung, colorectal, and ovarian cancer. We took their data and we created a model to identify who to screen. So right now, there's no good way to screen for ovarian cancer. And what we did, we took 150,000 patients and kicked out most of them. So the rate was 25 cancers out of $140,000. So we screened everyone once, we kicked these out, and we only focused screening on these 3,000 patients. So a much better ratio of 87 cancers to 3,000 patients. And the goal is to repeat screening once a year and then kick people out continuously until we identify a certain threshold where we can intervene. The model performs fairly well, at least in this setting, with a specificity of 98%. And some calculations show that we could eliminate 600 to 800 cancer deaths a year, which is less than 10%, but right now we're not eliminating any cancers. And it does shift the um, uh, the paradigm from looking for new screening, which we need to do to actually changing the way we screen for disease and identify patients eligible for screening. Another thing that kind of the opposite of a low frequency, high mortality is a high frequency, low specificity syndrome. So these are your urinary tract infections, headaches, pain, respiratory infections. Um, and we both under and over treat this, and there is significant risk. And we can also misdiagnose or mischaracterize what is due to these symptoms. A few years ago, we developed a model to predict the likelihood of someone having a urinary tract infection if they come in with a urinary symptoms to the emergency room, which is about 15,000 patients per year. And some of these patients can have other pelvic floor disorders. So these are primarily women being discharged, not males or people being admitted. And what we found was our model performs significantly better than standard urinary microscopy. And if we link this to a human being, so either a pharmacist who will call the patient back and they change their medication or um, um, stop a medication or start them on a medication, as well as a visit to an advanced practice provider to further evaluate their symptoms if this is more than their first event. We can actually improve care without overutilizing um, um, antibiotics and also drive revenue to the hospital. And if it works for UTIs, it will work for other similar conditions. Right now, we're running a prospective trial in an ER, and hopefully we can do a randomized trial across all ambulatory settings shortly. One final application potentially is capturing typically hard to capture data. So these are things like patient-reported outcomes, which are becoming much more integral to both just clinical care as well as to uh, research and linking this to medical records. So right now it's very cumbersome. Patients get questionnaires, they want to fill these out. And working with a partner, we developed a conversational agent that can capture this. And I'll just play this just very quickly, not the whole thing, just to demonstrate what it can do. This is after a vaginal hysterectomy capturing urinary symptoms.
Urinary symptoms. Okay, I'm ready. Great. Let's begin. Do you experience frequent urination? Sometimes. How much does frequent urination bother you? Not at all, slightly, moderately, quite a bit, or extremely? Moderately.
So it's kind of more of the same. But there's 6 questions and it's very easy. Somebody post up just gets this message, they click the link, and there's a written option as well where they can just enter data if they don't want to go through all this. But this is especially in urogynecology, very difficult to capture data, and it's basically all our treatment paradigms on based on validated questionnaires, which you are not able to capture in a large group of people. So if this is works, then we can really truly measure, create like big data sets that can analyze treatment options better for patients. Um, Another sort of variant of this is our conversational agents that can help with remote care. So this is from a company called Renalis. This is an app called Cece, which is meant to help people with pelvic floor with urinary incontinence with promoting pelvic floor physical therapy. So it actually walks them through specific exercises. It functions as a bladder diary and behavioral change agent where it can help them identify what's potentially causing this. And we've run some studies on this and it actually is quite effective. And right now we're trying to roll this out as part of a kind of a completely virtual health platform where patients in rural areas and urban areas that have difficulty with accessing subspecialists, that they can actually just meet with us via the phone. We train their local providers to do a pelvic exam to rule anything out anatomically. And then they do this for several months and only come to see us if they need more advanced care. And again, this can be translated to any similar problem across all medical disciplines. So those are the kind of the kittens and butterfly component of what AI can do. And because I'm a natural pessimist, this is my favorite part to talk about. And my favorite quote is, when you invent the ship, so this is one of the earliest canoes, you also invent the shipwreck. And when you invent AI, you invent the Terminator. Um, and what healthcare with AI has done is they've sort of taken this mentality of Silicon Valley, which is move fast and break things. Um, and this is still the philosophy, but they've actually broken things and have killed people outside of healthcare. So that with self-driving cars, there have been multiple deaths. There's plenty of data that Facebook has like stoked ethnic tensions around the world, most notably in Myanmar. It is directly responsible for political polarization and proliferation of misinformation. And there's very, very clear scientific evidence that social media is absolutely terrible for developing brains. And even to date, there's very little regulation of this type of technology, all because on the argument that it stifles um, innovation. In healthcare, the stakes are at least as high, if not higher, and the things we're breaking are people. And I think we need to proceed fairly carefully, even more so than the tech, well, definitely more so than the tech industry. So one of the biggest risks is with generative AI, and it's based on its function. We have zero um, paradigms for this. We've never integrated this type of technology. Some people compare this AI to like EHRs and certain medical devices, but something like this has never been done, where we're sort of ceding control of medical decision making to something other than a clinician. Um, and hallucinations and this use of overconfident language is a big problem. There's actually documented harm that has been done from this. Google had something called MedPalm 2, which was a patient-facing um, uh, um, sort of large language model regarding healthcare that told people outright incorrect information about cancer therapies. There was an example in Denmark where a similar model told a patient they only had 6 weeks to live, which they didn't. They were perfectly healthy. Um, there have been episodes. There's something called Wobot, which is a AI-based therapy app that misrepresented itself as a human being, and the can't remember the name of the organization, but it was the National Organization for Eating Disorders that used an automated chatbot that would tell people calling in for help with eating disorders that they just needed to lose weight. Clearly not optimal. Beyond that, there may be issues with documentation. Yes, scribes are great, but if we're still not looking at that information, there could be significant errors placed in there, and these errors can be compounded with every subsequent note. And in any sort of AI, it requires patient data. And then what happens to that data? Can that company then sell it to somebody else? What happens when there's a huge data leak? I've had to change my password from Google like 50 times already just in the last month because they keep having data breaches. But this is healthcare data. None of this is actually truly being addressed in any meaningful way currently. Beyond all that, there's that same problem that we have in routine clinical research, which is algorithmic bias, and that's introduced in the type of data we're using. And then we're applying models that are built on populations um, for whom that are different than the populations that we're applying to without any sort of mechanism of testing if it works the same. Even stuff like generative AI, which is kind of more less deterministic, it can subtly encode stereotypes because that's what exists in the data that it's being trained upon. Again, examples of this where Optum underestimated health risks in African Americans being discharged from the hospital, resulting in higher rates of readmissions in those populations. There are genetic algorithms used to predict disease, but these are skewed towards people with European ancestry. And there are um, also AIs that are also being used clinically for predicting insurance claim denials and no-show rates that are also very, in, let's say, inequitable to be generous. And this is all related to the data that's being fed into them. Um, Drift is another major problem that I don't think is being addressed correctly with models. And this is just based on how this can even occur when a model is successful. And even when we implement the model, healthcare isn't static and the inputs are going to change. So like data drift is when the input changes. An easy example is when we use ICD codes to define what a disease is. And we use, for instance, ICD-9 codes. Well, now we have ICD-10 codes, and those are significantly different. And the model based on ICD-9 codes becomes irrelevant. Same thing with ICD-11 when we get that. Concept drift is when is sort of the model becomes a victim of its own success. So we have a model based on vital signs and lab values that predict sepsis, and it reduces the risk of sepsis when somebody gets transferred to the ICU. People are going to start reacting to those markers. They're going to address bad vital signs sooner, even without the model. So now the relationship between the input and the output changes, and the model becomes useless unless someone's monitoring those changes and adjusting the model for that. And then label drift is sort of a change in distribution outcomes. And this was best illustrated with respiratory symptoms. Prior to 2019, people would walk in with a cough. They could have a bronchitis or a community-acquired pneumonia. They get an antibiotic or some asthma treatment, and then they go home. Well, the cough is different now in 2020 and beyond. And a lot more people are coming in with coughs, and it's actually something a lot more serious. And a model that was used to develop to predict what the cough is in 2018 is not going to be as useful in 2020. And it seems fairly easy to adjust for this in our heads, but if you have something that's deployed across either the whole country, even an entire health system, it may be really hard to change that. And the models perform much more poorly and then they become unsafe. And it also leads to significant waste and resources in developing the model early on. Um, Beyond all that, I promise I'm not piling on. There will be a positive component to this at the end. We are not validating or approaching AI models, especially in clinical care, the same way we approach drug therapy and surgical devices. All these drugs are commonly used. They have hundreds of sites. They are follow up for weeks, if not years. They're all randomized trial designs. They have post-market follow-up. CAR T cell therapy has a 15-year post-market follow-up with AI models. They're not even measuring the correct thing. There is an autonomous model for predicting diabetic retinopathy in the absence of an eye specialist. And it was an RCT, but their outcome was how good is it detecting retinopathy? Not is it preventing blindness? Not how well is it performing in the real world? And most AI studies do just this. They prioritize evaluating technical metrics, but not the harm or even the utility of what the model is and what it's trying to do. It's how good is it at prediction, which all of these are going to be better at prediction than what we currently have. It's just, is it really better in treating disease, which is what we're trying to use it for. Um, the other problem is the model data was much better than it is now, and the rate of fraudulent data or just incorrect data is just atrocious. There's a study last year or recently, just a few weeks ago, that was published that the rate of fraudulent paper doubling is exceeding the rate of actual scientific publication. This is what these models are using to be trained on. It's also estimated by the end of this year that 90% of internet content is going to be completely AI generated. And some of this data is going to be poisoned because competitors who build models are going to put incorrect data to try to hurt their competitors to create bad models. So it's just kind of becomes a self-fulfilling cycle. And when you're using AI generated rather than human data, it's going to cause model collapse. It's going to amplify significant errors. You're going to have loss of diversity of effects. So you're only going to look at common patterns rather than more rare things, which is the real utility of AI. And it's going to make human produced data way more expensive. There's also a little bit of a performance paradox. The people most eager to implement this and saying that AI is going to replace doctors are also the ones who least understand how to implement it and what it's actually capable of doing. We have these great models, but we have no mechanisms for implementing them or deploying them successfully. And there was a study out of MIT that found that 95% of companies that invested in AI saw a 0% of return on investment. This was because there was no integration strategy. They were using generic tools to try to address specific problems. There was no way of keeping a person in the loop. They would just fire the person whose job AI was supposed to be doing. What they did find was that in the 5% that there was a significant ROI was that these AIs that performed best and were focused on a very, very narrow task. And that's also true for healthcare. And in healthcare, things are much more complicated than, say, in a finance company. Patients are heterogeneous. Most of the things that even we're currently using haven't really been well studied outside of a controlled environment. And they definitely perform worse in the real world, maybe not dangerously worse, but the improvements are much more incremental. And there's currently no real system to adjust for this sort of messiness. Um, Other than sort of the dangers of the AI itself, the more we use it, the more we're going to lose the skills that are necessary to being a good clinician. And that even includes clinical documentation. That's really a good note is a communication with your future self and your colleagues. And if you're just relying on AI, you're going to forget or at least lose the skill that is meant to um, um, let you write a clean, effective note that promotes medical care. It will limit the amount of communication we have with patients and with our colleagues. It will even affect our procedural skills. There was a study of gastroenterologists in Poland where they had AI to detect adenomas, and then they took it away. And compared to pre-introduction of the AI, the rate of adenoma detection decreased by 20%, which is pretty significant. And finally, if we're just relying on AI to do everything, there's going to be way less cognitive engagement, and medicine is going to become even more of a commodity than it already is. Um, Aside from all those things, there's also no regulation. Right now, there are some pathways for approving AI technology for clinical care, but it's kind of a variant of device approval. Um, and it's static. And if an AI model, as I just discussed, works correctly, whatever model you start with is not going to be the one you're going to have even a year from when you introduced it. And there's no process for continuous clearance or approval of these evolved models. And until there is one, there's going to be way, way more off-label use and potentially non-supported applications of these models, even though they were quote unquote FDA approved. And lastly, there's this concern of what happens when something goes wrong? Who do we sue? This isn't like a lab test that was just missed or an imaging diagnosis that was like not communicated to the clinician. And we don't even know how this thing work. If you have an elevated white count, you know how the lab test did that. If an AI comes up with an outcome, we don't know how it got to that. And it's often not communicated to us because it's a company secret. So how do we use a tool that we don't understand? There's also now potentially for laws that are going to penalize clinicians for not using AI. So you're going to get sued for using it and you're going to get sued for not using it. And that's going to, I think, those that actually comes to fruition, we're going to lose a lot more clinicians. And then are patients ready to accept decisions based on AI? How do we communicate that to them without burying it in paperwork, but also without extending a conversation by 30 minutes with each single patient? And how liable are institutions? And it may actually end up costing the institution more to deal with the risk mitigation of AI than the AI itself, and as well as to adhere to all the regulatory requirements. Um, so there is, despite all the negativity, there is a path forward. Um, we can effectively deploy and implement these if we do this very carefully and deliberately, and thoughtfully. If by creating AI governance boards, this is already happening, and that will continually monitor. Um, any sort of model that we're or application that we're using in a clinical setting, even if it's just note writing or some administrative task, that there are ethics boards that separately from governance boards that can identify potential ethical concerns regarding these models, and if and some sort of system to continually monitor these models to make sure that they're not succumbing to drift and model collapse. They're still doing what they're supposed to be doing. Um, Carefully, whenever we acquire a new model, apply it to a new population, we rigorously test this in a subset of these patients that we're trying to apply it to, that we're not misdiagnosing or causing harm, and trying to include these models in populations that need it most. So for right now, it seems that applications in actually more marginalized communities is better than somebody who has clear access to clinical care. But because of the way we get paid, it may actually be implemented more in people who with means rather than people who most benefit from it. Um, and we create a very, very comprehensive mitigation strategy where we have tiered risk by low risk administrative tools to high risk diagnostic tools and prognostic tools. And then we hold vendors accountable because if there's a problem, it's their fault as much as ours, and maybe it's more their fault. And also have this very nimble team that can adjust for any sort of regulatory changes because as this continues to evolve, this is moving really fast. Again, there's no real parallel to what's going on now with AI and healthcare. So somebody needs to be always, always up to date on what's happening and basically just screen the internet and CMS website for any new development every single day. That is it. Thank you.
Oh wow, that was a lot.
That was a lot. Yeah.
Thank you very much, David, for that. I don't know if uplifting is the right word, but certainly thought-provoking and relevant, uh, timely discussion. Um, as moderator, I'll take my prerogative to ask the first question. Since we're here, as for the HSR, center's grand rounds, um, one of the things that the questions that came to mind as you were talking about all these sort of rapid shifts and changes and challenges and how this affects the ways that we're approaching or we what we even need to think about from both the clinical benefit, a policy perspective, and a research standpoint. What are your thoughts on what new skills or frameworks or perspectives that health services researchers need to develop or potentially help to to build or create consensus on in order for us to keep contributing meaningfully to advancing the state of science and to support public health in the setting of AI deployment in this sector.
I think health services research very much goes hand in hand with AI. It's all big data. I think just basically understanding what is currently being done in research, what is possible. I think coming to consensus on what defines a specific condition, because and creating these sort of phenotypes, electronic phenotypes, I think would be a big part of health services research. Like what's an important outcome? What's a reliable outcome? Um, and then I think creating even like research ethics boards around AI and like what should be done, what could be done, what are the minimum events. So right now, the kind of the rule for validating AI is you have to have a data set with at least 100 events. So if you're looking for like ovarian cancer, you need a data set with 100 ovarian cancers. But then what's the denominator? Is it like another 100 of controls? Is it 1,000? Is it
Mhm.
2,000? I think coming up with rigorous methodology and definitions for what is a good study versus a crappy study. And I don't think that's really been done yet, right? There's a tripod statement, which is similar to consort but this is like a brave new world. This is a wild west. So I think even just coming to a consensus of what's a valid input, output, like what's a valid study versus not a valid study in this space, I think would be a good place to start.
Yeah, it seems particularly challenging, or uh, there seems to be a particular disjoint just in a certain way from the fact that, as you mentioned, with generative AI being coming out of a black box and being non-reproducible, that this is contributing that its contribution to the medical literature is increasing so rapidly, while at the same time, there's all this push in general for increasing transparency and, publicly accessible databases and things like that to
Right.
to shift the curve in the other direction.
Right, right. And as long as there's going to be these third-party vendors, it's going to be hard to get transparency because you can't patent
Yes.
AI. It's
Right.
it's always going to be a trade secret, and they're going to be very reluctant. I even think like one path forward is to have hospitals individually make their models, like and that will reflect more
Mm,
their populations, like even within like Cleveland, like Metro's
yeah.
population is different than ours and is different than the clinics, and if we each have our own model which wouldn't, depending on what it is, wouldn't be that hard to do if we have the appropriate systems in place.
Fair. I want to make sure that I also give a chance for our attendees to have their questions put out there. A good sort of broad level one is from an anonymous contributor. That sort of just goes back to the garbage in, garbage out type of thing, right? And the acknowledged uh, relevance of biases, uh, in our current human-based clinical practice and how that can be perpetuated through generative AI. So there, our attendee was asking if AI uses data that is fed from various sources, how can we as humans help to mitigate the stereotypical biases mentioned?
That's an excellent question. I think there are programs right now by the NIH and others that are trying to standardize the way we collect EHR data. Um, it's hard putting the onus on clinicians, like be careful with what you're clicking. But I think as like EHR and Epic evolve and other platforms evolve, I think it'll become a lot more easy to collect reliable data. Right now, the data is like, wholly unreliable. With regard to addressing the systemic biases, I think making sure that you have enough of specific populations that you're applying these models to, or if you don't, at least calibrating them in those people before you deploy it successfully. So say somebody builds a model and we want to use it here at UH and our population is way different. We would at least try to take a subgroup of that population and recalibrate that model to what is important for us. And then it becomes a third party vendor, like how much tinkering can we do with a
Mhm.
model like this? Where I think it goes back to it may be easier if we do it ourselves.
Along a related line, based on sort of my personal experiences and conversations I've had, what are your thoughts on, in general, I think as a big data person myself, I tend to think more data is better data.
Yeah.
When it comes to LLMs, or generative AI, I I've shifted away from that. Even in things like, when writing letters of recommendation, for graduating fellows or things like that. Knowing that there are biases that are going to be perpetuated by the LLM on the basis of sex, gender, race, ethnicity. I have consciously removed, when I use LLMs for that purpose, I've consciously removed data from the input that I'm providing that could create a bias. Do you feel like in the healthcare setting, you know, I've, in our field, for example, we have this ongoing conversation about, do we include, this is a 19-year-old African American male. Is that relevant? Is that helpful? Is this perpetuating bias to include that? What are your thoughts on whether or not to decrease the data input?
Well, I think we have to understand because, like I mentioned, LLMs are giving you what's plausible, not what's, and maybe being a 19-year-old African American male is important, but we don't know. And I think doing studies on 19-year-old African American males versus 36-year-old white males or females or Asian children, it will help us identify whether or not that's important. I think we have to, this is why I think keeping a human in the loop is important instead of just feeding it a ton of data. I also use it to uh, write clinical or letters of recommendation. I do go in and take out any sort of gendered terms and take out the name and everything. And it gives me like a very gender neutral basis from which I can then write a letter that
Sure.
becomes more personable. But there's an example of this with Amazon was using AI to screen for engineers. And they screen for a specific language, and it was typical language being used by male engineers. So they basically screen out every single female applicant.
Right.
Um, and there is a real danger in that. And again, I think if we as like collectively as clinicians and as people implementing this say we need to be careful about this, then we will be careful about this. If we just kind of roll over and say, oh yeah, the
Right.
model's here, then that it's what's going to happen is we're going to have like real bad stuff happening. Like even though the road to hell is paved with good intentions.
Absolutely.
So I think just being very cognizant of what the harms are, which is why I highlight the harms so much. I'm actually like really pro AI despite the talk. I just think really understanding the harms, we can avoid them. We won't avoid all of the ones, but there are very obvious ones we can be aware of and prevent them from happening. Like there is no excuse to have a model that leads to worse outcomes in African Americans. Like anyone, a child could tell you that that would have happened.
Right, right. Well, and yet, as you mentioned, so often it does. I remember an early example that from just listening to news development was another hiring one where I think they were trying to hire, it might have been for an attorneys or something like that. They were trying to hire few screen candidates on the basis of successful candidates. And then when they look back at what was the most significant data point, it was first name. And if you
Right,
had a male white first name,
right,
that was the single largest data point that drove hiring decision that the AI
right,
then latched onto because it said, oh, well, that was the driver. Um,
right.
Other questions that we have, there are a number of them. Nihit Mehta asked, there are many medical professionals who feel that adopting AI will cause a third party to enter the patient-provider relationship. Is there a way to sort of bridge the gap for them?
I think being again going being honest with we're using AI to uh make this prediction or make this decision together. We already sort of do this with like, from one example from when I was a resident, we would tell people about their risk of having a vaginal birth after a C-section. We wouldn't actually discuss with them where that information came from. We just said you have an increased risk. So I think now there is an onus on us to discuss like these are we're making this decision based on these tools. This is what the tool is based on. What do you think? We have some qualitative studies going on right now both for clinicians and patients to see how like what do they need from us to describe it. We can't just say now if we're using AI like oh go deliver at this hospital for gestational diabetes because the AI said so. We have to have a discussion. And we already have third parties, Medtronic is a third party.
Hmm.
But we're using it as a tool. This is like more of almost like a decision aid. And we have to, I think, be able to share that with patients more so than just putting a piece of paper on the wall that says we're using AI now. Um,
Yeah, no, absolutely. Um, One last question. I know we're running out of time. One last quick question. Nita Hoxa asked, is the screening that you mentioned of ovarian, pancreatic, bladder cancer built into Epic, or is it a separate platform?
So this isn't actually a platform now. This is like purely theoretical that we've built where it's currently under consideration at a journal. But the idea is things like this, like the UTI that I mentioned, will become integrated into Epic, and then clinicians can use this as a way to make decisions.
And we are past the noon mark, so I want to be respectful of everyone's time, both our attendees as well as your own. Thank you so much for all of your help and insights and experiences and your engagement with our questions. So I really appreciate the thoughtful discussion.
Thank you. Thank you for having me.
Thanks, David.
Cool.
Bye-bye.
Bye.